Hello everyone, let's begin the next part of the video which is most awaited since long time. It is the treatment of hypocalcemia. Dr. Ankit will be discussing this part today with you guys. Right, as I told that hypocalcemia in generally we saw that when the levels of calcium in the blood they go beyond or less than 8.5 milligram per deciliter, we call it hypocalcemia, right? This is the first step. We have to check the levels of the blood in you have to check the levels of the calcium in the blood first, right? Then we have to get a baseline ECG done in that particular patient. You have to check for the ECG, which will have prolonged QT interval, will have prolonged ST interval, right? Patient can land up into atrial fibrillation also. You can see here in this ECG is a very basic ECG rhythm, just showing serum calcium levels less than 8.5 milligram per deciliter. The ST segment is lengthened, the QT segment is lengthened, and it can line up into, as I told, atrial fibrillation and torsades de pointes. Next thing, we have to check that we have to identify the cause by the lab test, right? We have to check for the levels of parathormone, parathyroid hormone, the vitamin D, phosphorus, albumin levels, and magnesium. Highlighted albumin because of a certain reason, as I told in the previous video. Go back to the part 1 and see why I have used this red color highlight in case of albumin. One thing we have seen that in this particular scenario where the calcium levels are low, you have to check once the hypocalcemia is corrected or not to rule out pseudo hypocalcemia, right? In certain scenarios, check for the levels of parathormone hormone. Either it can be increased or it can be either low or normal. If it is increased, we should know that the parathormone is present obviously in the serum, but it is ineffective. At that point of time, we have to check for the vitamin D levels in the body. It will be either normal or it will be either low, right? Normal vitamin D cases will have parathormone resistance, such in case of uremic environment or bisphosphonates therapy in the patient. Also, because of chelation, the same scenario happens due to hyperphosphatemia, due to certain infections like pancreatitis, alkalemia, right? Any solutions which contain citrates, as we all know, in case of blood transfusions, the calcium will bind to the citrates and the levels will go down in the blood. Any patients receiving phoscarnet therapy, right? Or any patient having ethylene glycol toxicity. In case of vitamin D deficiency, the levels of the vitamin D go less than 15 nanograms per deciliter. Certain scenarios obviously will take us to the diagnosis of low dietary intake. Severe liver disease, enzyme inducers like 450, P450, right? And any case of end-stage renal disease or advanced renal disease, right? In certain scenarios, the question might arise in the mind that in this case there might be hypercalcemia, right? But it's not true. Advanced renal disease can lead to decreased activation of 125 dihydroxycholecalciferol, right? And ultimately it will lead to hypocalcemia. Okay, this is the scenario here. Now, in certain cases of when the parathormone hormone is low or inappropriately normal, this scenario, we have a simple diagnosis of hypoparathyroidism. Okay, this is the scenario. Now, in case of this, obviously, because of this, there's a reason coming, which is parathyroidectomy. Somebody is having surgery of parathyroid hormone or parathyroid, I'm sorry. Radiation induced destruction of the gland. Any case of autoimmune diseases. Wilson's disease. Okay. Obviously, HIV can affect this particular scenario. HIV infection can affect this. Okay. This is the scenario which we have seen in case of low parathyroid hormone. Okay. Now let's go to a certain special scenarios in which we can see hypocalcemia. We have three scenarios here. One is very important, which is pseudo-hypocalcemia. The other one is chelation. The third one is sepsis. Right. Now let's talk about the pseudo-hypocalcemia. Here, we should know that this approximately 45% of calcium, this is in ionized form, right, in the serum, and it is a free ionized form, not a bound one. Okay. Now what happens when there is a change in the serum albumin? What happens because of this? The serum anions, okay, the serum anions, they get altered because of the total measured serum calcium level. Okay. And ionic calcium levels here remains unchanged. Okay. And we all know that hypocalcemia, the hypoalbuminemia is a very common scenario in the ICU. Okay. Because in case of any disease like any infection or sepsis or SIRS, the albumin levels go down. Okay. Or in the case of large fluid resuscitation, sometimes large clear crystalloid resuscitation happens. Because of that, what happens, there is total measured serum calcium level gets low, right? But in this case, the ionic calcium remains normal, isn't it? So this scenario, what will we see? There is a scenario in which if there is a reduced serum albumin levels, we have to always remember that each 1 gram reduction in albumin levels, we have to add 0.8 milligram per deciliter to the measured calcium levels in the ICU, right? And for this level, we should remember the baseline albumin level should be 4 milligram per deciliter, not more than this. If it falls beyond this level, we have to add 0.8 milligram per deciliter of calcium levels in the equation or in the calculation, right? Now, second scenario we see, this is the chelation. A simple thing to understand that any ion which will combine with the calcium in the serum will cause a reduction in the serum calcium levels. As simple as that. The free calcium or the ionic calcium which is available in the blood will not be available because of it is binding with the anion there, right? And this will happen when there is a negatively charged fatty acid present in the body. When will this happen? A simple scenario. Examples like any infection, take pancreatitis, right? Rhabdomyolysis, any infection which will increase free fatty acids in the body will cause binding of calcium in the blood, from the blood, and it will cause a reduction in the calcium levels in the body, isn't it? Now what happens because of, suppose take a case of same scenario, take a case of parathyroid surgery, right? Parathormone surgery. In this scenario, what happens? There is a massive release, isn't it? Massive release of parathyroid hormone causing calcium binding, isn't it? Also, the chelation by components in the blood, which is citrate, will cause a reduction of serum calcium levels, isn't it? Now let's talk about the same scenario, sepsis here. As I told just now, because of sepsis, what happens? There is a negatively charged free fatty acids present. This will cause binding of serum calcium levels and cause a reduction in the calcium levels of the body, right? Let's talk about the final part, which is the treatment, right? In this scenario, we should know that the main goal of any patient having hypocalcemia, we have to correct the cause of the hypocalcemia first, as I have discussed here. Next thing, we have to check for the symptoms and the ECG of the patient. ECG, as I have shown just now, to see for the changes and the symptoms that are present in the hypocalcemia discussed in the part 1 of the video. You have to begin rapid IV replacement of the patient, right? This we should remember. Now, what we have to do? We have to take certain drugs for the same, obviously, which is calcium gluconate. You have to take 2 grams of calcium gluconate, which is 20 ml or 2 ampules of 10% calcium gluconate, right? You have to mix this with 50 to 100 ml of dextrose, 5%, or NS. Give it IV over 10 to 15 minutes. One thing we have to see like this. Second thing, you can take continuous calcium infusion. Take 6 grams of calcium gluconate, right, in 500 ml of D5 or NS. Infuse this at the rate of 0.5 to 1.5 milligram calcium per kg per hour, right? Next thing, check for other levels of ions. Suppose the patient is having hypomagnesemia. Take 2 grams MgSO4, give it IV over 15 minutes, right? Obviously, check for RFTs before this. Check for deep tendon reflexes before this, right? This is the scenario. Now, in this, we can add 1 to 2 gram elemental calcium, right? Orally, TDS or QID. This one we have talked about the acute hypocalcemia, right? Now, what about the chronic one? In this case, what we have to do, we have to give high oral calcium intake along with vitamin D supplements, right, which will contain 40% of elemental calcium, right, and this will correct the levels of the calcium in the body gradually, right? And obviously you can give ergocalciferol, which is almost 400 to 1000 international unit per day. Okay, obviously you can remember one more thing, 6 to 8 weeks of 60,000 international unit weekly. Okay, in patients of ESRD, you can give this where there is renal insufficiency in the patients, right? In the next part, we'll be discussing hypercalcemia, and this is obviously a complication of the aggressive treatment of this particular therapy of hypocalcemia also, and there are certain other scenarios also which we will discuss in the next coming videos. Thank you so much.